Block simulation. 4T. Same process, fresh set. Read the command first, scan the clues, build fast, lock, and move. 20 questions, 30 minutes. Clock starts now. What do the central chemoreceptors directly detect to drive ventilation? A healthy person voluntarily holds their breath. As CO2 rises and pH falls, an irresistible urge to breathe builds. A physiologist explains that the primary driver of ventilation at rest is sensed in the brainstem. Read the command. What central chemoreceptors detect? CO2 rises, drives breathing. Central chemoreceptors sense CSF PHEH+ from CO2 diffusion. The central chemoreceptors located in the medulla are the primary drivers of ventilation at rest. They do not sense oxygen or CO2 directly. They detect the pH or hydrogen ion concentration of the cerebrospinal fluid. CO2 from the blood readily crosses the blood-brain barrier into the CSF, where it combines with water to form carbonic acid, which dissociates to release hydrogen ions, lowering the CSF pH. The central chemoreceptors sense this drop in pH and stimulate increased ventilation to blow off CO2. So CO2 acts indirectly through the pH change it produces in the CSF. The correct answer is A. The division of labor, the central chemoreceptors respond to CSF pH driven by CO2 and set the resting respiratory drive, while the peripheral chemoreceptors in the carotid and aortic bodies respond to low PO2, mainly below 60, as well as to high CO2 and low pH. Oxygen is sensed peripherally, CO2 pH centrally. The central chemoreceptors detecting CSF hydrogen ions from CO2 is the resting ventilatory driver. Why does this complication characteristically occur several days after the infarct? A 62-year-old man who had a large anterior myocardial infarction 5 days ago suddenly develops profound hypotension, distant heart sounds, and jugular venous distension, then arrests. Autopsy shows rupture of the ventricular free wall with blood filling the pericardial sac. Read the command. Why free wall rupture occurs days after MI. Day 5 post. MI, free wall rupture, tamponade. Macrophage clearance of necrotic tissue maximally weakens the wall before scar forms. Free wall rupture occurs characteristically 4 to 7 days after a myocardial infarction because of the timeline of healing. In the first day, there is coagulative necrosis, but the dead tissue is still structurally present. From about day 3 to 7, macrophages infiltrate to clear away the necrotic debris. While this is necessary for healing, it transiently leaves the wall at its W. Egester. The dead muscle has been digested away, but durable scar tissue has not yet formed. Mechanical stress on this softened wall can cause rupture, leading to hemopericardium and cardiac tamponade. The distant heart sounds, hypotension, and JVD here. The correct answer is E. This fits the broader MI complication timeline. Arrhythmias in the first day, free wall rupture, papillary muscle rupture, and septal rupture around days 3 to 7, macrophage phase, and a true ventricular aneurysm or Dressler syndrome weeks later, once a thin fibrous scar has formed. The macrophage-mediated softening of the wall before scar maturation explains the characteristic several-day delay before rupture. A deficiency of which vitamin and its coenzyme role explains this. A 30-year-old man with a restricted diet presents with cracking and inflammation at the corners of the mouth, angular cheilitis, a sore magenta-colored tongue, glossitis, and corneal vascularization. There is no dermatitis, diarrhea, or dementia. Read the command, which vitamin and role. Angular cheilitis, glossitis, corneal vascularization without the pellagra triad, riboflavin B2 deficiency, fattifin. Riboflavin, vitamin B2, is the precursor of the flavin coenzymes FAD and FMN. These are essential electron carriers in redox reactions throughout metabolism, including the electron transport chain, the TCA cycle succinate dehydrogenase, and fatty acid oxidation. Riboflavin deficiency classically presents with the two C's, cheilosis angular cheilitis, cracking at the corners of the mouth and corneal vascularization, along with glossitis, a magenta tongue, and seborrheic dermatitis. The correct answer is B. The mnemonic for riboflavin deficiency is the two C's, cheilosis and corneal vascularization. The key contrast here is the absence of the pellagra triad of dermatitis, diarrhea, and dementia, which would point to niacin B3. Both are B vitamin deficiencies with mucocutaneous findings, but cheilosis and corneal vascularization without the 3Ds point specifically to riboflavin, whose role is forming FAD and FMN. From which spinal roots does this nerve arise, and why is the pain referred to the shoulder? A patient with a lung mass at the apex has irritation of the diaphragm. He reports pain referred to the tip of his right shoulder. During surgery, the nerve supplying the diaphragm must be identified and protected. Read the command, roots of the nerve and why shoulder referral. Diaphragm irritation, shoulder tip pain, phrenic nerve, CC3-CC5, referred via shared C3-C4 dermatome. The diaphragm is innervated by the phrenic nerve, which arises from spinal roots C3, C3, C4, and C5. C3, 4, 5 keep the diaphragm alive. The phrenic nerve provides both motor innervation for breathing and sensory innervation to the central diaphragm and overlying pleura and peritoneum. Pain from diaphragmatic irritation is referred to the tip of the shoulder because the shoulder skin is supplied by the supraclavicular nerves from the same C3-C4 cervical roots. The brain cannot distinguish the source, so it localizes the diaphragmatic pain to the shoulder dermatome. The correct answer is B. This referral pattern is clinically useful, irritation of the diaphragm. From a subphrenic abscess, splenic rupture, gallbladder disease, or, as here, an apical lung process produces shoulder tip pain. The mnemonic C3-4-5 keep the diaphragm alive, anchors the roots, and the shared C3-C4 dermatome with the shoulder explains the referral. The phrenic nerve from C3-C5 is the answer. What is the most likely cause of his acute kidney injury, and which segment is most vulnerable? A 60-year-old man develops acute kidney injury after major surgery complicated by prolonged hypotension. Labs, creatinine rising, urine sodium high, 40. Fractional excretion of sodium 82%. Urinalysis shows muddy brown granular casts. Read the command, cause of AKI and vulnerable segment. Post-hypotension, AKI, high urine sodium, FeNA over 2%, muddy brown casts, ischemic acute tubular necrosis, proximal tubal and thick ascending limb. This is ischemic acute tubular necrosis, the most common cause of intrinsic acute kidney injury. Prolonged hypotension during surgery reduces renal perfusion, and the tubular epithelial cells, which have high metabolic demands, die. The diagnostic urine findings distinguish ATN from a pre-renal state. In ATN, the damaged tubules can no longer reabsorb sodium, so the urine sodium is HGH above 40. The fractional excretion of sodium is elevated above 2%, and the slough-dead tubular cells form the characteristic muddy brown granular casts. The correct answer is C. The two most vulnerable segments are the proximal tubule straight portion and the thick ascending limb of the loop of Henle, because both have very high oxygen and ATP demands. Contrast with prerenal azotemia, where the tubules are still intact and avidly reabsorbing sodium. So urine sodium is low, FeNA is below 1%, and the BU-creatinine ratio is high over 20 with no casts. The high FeNA and muddy brown casts confirm ischemic ATN. What property allows HbF to pull oxygen from maternal HbA, and what is the mechanism? A physiologist compares fetal and adult hemoglobin. She notes that fetal hemoglobin, HbF, alpha-2 gamma-2, extracts oxygen from the maternal circulation across the placenta. Read the command, property allowing HbF to pull oxygen and mechanism. HbF has higher oxygen affinity because it binds 2003 BPG poly. Fetal hemoglobin has a higher oxygen affinity than adult hemoglobin, which is what lets the fetus extract oxygen from the maternal circulation across the placenta. The mechanism is its interaction with 2003 bisphosphoglycerate, or 2003 BPG. 2003 BPG normally binds to the beta chains of adult hemoglobin and lowers its oxygen affinity, promoting oxygen release. Fetal hemoglobin has gamma chains instead of beta chains, and the gamma chains bind 2003 BPG LES avidly. With less 2003 BPG bound, HbF holds onto oxygen more tightly, higher affinity, a left shifted curve, so it can pull oxygen away from maternal HbA. The correct answer is C. This affinity gradient, fetal hemoglobin higher than maternal, ensures net oxygen transfer from mother to fetus across the placenta. After birth, HbF is gradually replaced by adult HbA over the first 6 months. The key concept, the gamma chain's poor binding of 2003 BPG, gives HbF its higher oxygen affinity and left-shifted dissociation curve, allowing it to extract oxygen from maternal blood. What is the primary mechanism and main site of action of verapamil-diltiazem compared with dihydropyridines like amlodipine? A 70-year-old woman with hypertension and rate control needs for atrial fibrillation is given a non-dihydropyridine calcium channel blocker. She is counseled about constipation and the risk of bradycardia. Read the command, mechanism, and site of verapamil-diltiazem versus dihydropyridines. Non-DHP CCBs act on the heart, AV node, rate, DHPs act on vascular smooth muscle. Calcium channel blockers block L-type calcium channels, but the two subclasses differ in tissue selectivity. The non-DIY-PI-ridines, verapamil and diltiazem, act predominantly on the heart. They slow conduction through the AV node, useful for rate control and atrial fibrillation, reduce heart rate, and decrease contractility. That cardiac action is why they cause bradycardia, and verapamil notably causes constipation. The DIH-YPI-ridines, amlodipine, nifedipine, act predominantly on vascular smooth muscle, causing arterial vasodilation to lower blood pressure, with side effects like peripheral edema and reflex tachycardia. The correct answer is A. The clinical takeaway: use non-dihydropyridines, verapamil, diltiazem when you want to slow the heart, rate control and atrial fibrillation, SVT or angina, and use dihydropyridines, the dipines, when you want to dilate vessels for hypertension. Avoid combining non-dihydropyridines with beta blockers, since both suppress the AV node and can cause severe bradycardia or heart block. Verapamil and diltiazem are the heart-selective, rate-slowing calcium channel blockers. What is the cell of origin of this disorder? A 2-year-old child presents with bone pain, skin rashes, recurrent ear drainage, and lytic skull lesions. Biopsy of a lesion shows proliferating cells with grooved, coffee bean-shaped nuclei. The cells stain positive for CD1 and S100, and electron microscopy reveals tennis racket-shaped cytoplasmic granules. Read the command, cell of origin. Child, lytic skull lesions, coffee bean nuclei, CD1 and S100, positive, Burbeck tennis racket granules. Langerhans cell histiocytosis. Langerhans cell histiocytosis is a clonal proliferation of Langerhans cells. Specialized dendritic antigen, presenting cells normally found in the skin and mucosa, derived from the monocyte macrophage lineage. The diagnostic features all point to this origin. The cells have grooved, coffee bean, or tennis racket-shaped nuclei. They stain positive for CD1 and S100, and on electron microscopy they contain pathognomonic BIRBK granules, which look like tennis rackets. Clinically, it can present with lytic bone lesions, especially the skull, skin rashes, and in infants, multi-system disease. The correct answer is C. The 3 confirmatory markers to remember are CD1, S100, and Burbeck granules on electron microscopy. The clinical spectrum ranges from a single bone lesion to disseminated disease. The recurrent ear drainage and lytic skull lesions in a young child with coffee bean nuclei and these markers point to Langerhans cell histiocytosis, derived from dendritic Langerhans cells. Which organism is responsible? A full-term neonate develops fever, lethargy, poor feeding, and respiratory distress at 2 days of life and is found to have meningitis and sepsis. The mother had no prenatal screening. Culture bears a gram-positive coccus in chains that is beta-hemolytic, catalase negative, and hydrolyzes hippurate, CAMP test positive. Read the command. Which organism? Neonatal, sepsis is meningitis, beta-hemolytic, catalase, negative, CAMP, positive gram, positive cocci in chains. Group B, streptococcus. Group B, streptococcus. Streptococcus agalactiae is a leading cause of neonatal sepsis, meningitis, and pneumonia, especially in the first week of life, early onset. It is a gram-positive coccus in chains, beta-hemolytic, catalase negative, and identified in the lab by being CAMP test positive and hydrolyzing hippurate. The organism colonizes the maternal, vaginal, and rectal tract, and the neonate is infected during passage through the birth canal. This is why pregnant women are screened at 35 to 37 weeks and given intrapartum penicillin prophylaxis if positive, which this mother missed. The correct answer is C. The lab identifiers are the discriminator, GBS is CAMP positive and bacitracin resistant, distinguishing it from group A streptococcus, prophylaxis, which is bacitracin sensitive. The classic neonatal meningitis pathogens are group B strep, E. coli, and listeria, and the CAMP positive, hippurate positive, beta hemolytic gram-positive, cocci in chains identify group B streptococcus. Prevent with maternal screening and in trains identify group B streptococcus. Prevent with maternal screening and intrapartum prophylaxis. Through which receptor and mechanism does this hormone concentrate the urine? A patient becomes severely volume depleted and plasma osmolality rises. In response, a hormone is released from the posterior pituitary that acts on the kidney to conserve water. Read the command, receptor, and mechanism for concentrating urine. ADH acts on V2 receptors in the collecting duct, inserting aquaporin 2. The hormone is antidiuretic hormone, ADH, or vasopressin, released from the posterior pituitary in response to high plasma osmolality sensed by hypothalamic osmoreceptors or to significant volume depletion. To concentrate the urine, ADH acts on V2 receptors on the principal cells of the collecting duct. V2 activation works through cyclic AMP to insert aquaporin 2 water channels into the luminal membrane. With these channels in place, water is reabsorbed out of the collecting duct down the osmotic gradient into the hyperosmotic medulla, producing concentrated urine and conserving body water. The correct answer is E. ADH has two receptor types. V2 receptors mediate the renal water conserving effect just described, while V1 receptors on vascular smooth muscle cause vasoconstriction, raising blood pressure in severe hypervolemia. Defects in this pathway cause diabetes insipidus, central from lack of ADH, nephrogenic from V2 receptor or aquaporin resistance. The V2-mediated insertion of aquaporin 2 channels in the collecting duct is how ADH concentrates the urine. Against which structure are the autoantibodies directed? A 55-year-old man presents with flaccid, easily ruptured blisters and painful oral erosions. The blisters spread when lateral pressure is applied to nearby skin positive Nikolsky sign. Biopsy shows intraepidermal separation with the row of tombstones basal layer. Direct immunofluorescence shows a net-like reticular IgG pattern between keratinocytes. Read the command. Target of the autoantibodies: flaccid blisters, oral erosions, positive Nikolsky, intraepidermal split, net-like IgG. Pemphigus vulgaris, anti-desmoglein. Pemphigus vulgaris is caused by IgG autoantibodies against desmoglein, a component of the desmosomes that hold keratinocytes together within the epidermis. Destroying these connections breaks apart the cell-to-cell adhesion, acantholysis, producing fragile, flaccide intraepidermal blisters that rupture easily and painful oral mucosal erosions. The Nikolsky sign is positive. Skin shears with lateral pressure. Histology shows the suprabasal split, with the basal cells remaining attached, like a row of tombstones, and direct immunofluorescence shows the characteristic net, like reticular IgG pattern outlining the keratinocytes. The correct answer is A. The crucial contrast is with bullous pemphigoid. Pemphigoid antibodies target hemidesmosums BP180, BP230 at the dermal-epidermal junction, producing tense subepidermal blisters that do not rupture easily, a negative Nikolsky sign, oral sparing, and a linear immunofluorescence pattern. So pemphigus is intraepidermal, flaccid, Nikolsky positive, antidesmoglein. Pemphigoid is subepidermal, tense, Nikolsky positive, antidesmoglein. Pemphigoid is subepidermal dentions, tense, subepidermal blisters that do not rupture easily, a negative Nikolsky sign. Net-like IgG against desmoglein defines pemphigus vulgaris. A lesion of which structure best explains these findings, and on which side? A 58-year-old man with chronic hypertension presents with sudden onset of severe difficulty with coordination on the left side. Exam: left-sided limb dysmetria past, pointing, intention tremor, dysdiadochokinesia, and a tendency to fall to the left. There is no weakness or sensory loss. Read the command. Which structure and side? Left-sided dysmetria, intention tremor, dysdiadochokinesia, falls to the left, no weakness, left cerebellar hemisphere lesion, signs ipsilateral. These findings: limb dysmetria with past pointing, intention tremor, dysdiadochokinesia, impaired, rapid alternating movements, and a tendency to fall toward the side of the lesion are the signature of a cerebellar hemisphere lesion. The defining principle is that cerebellar signs are IPS lateral. A lesion of the left cerebellar hemisphere causes left-sided incoordination because the cerebellar output crosses twice, a double cross on its way to and from the cortex, so the net effect stays on the same side. The absence of weakness and sensory loss localizes the problem to the cerebellum, not the motor cortex or internal capsule. The correct answer is E. The ipsilateral rule is the key teaching point and the trap. Students expect cross findings because most motor and sensory pathways cross, but cerebellar hemisphere lesions produce same side deficits and patients fall. Toward the lesion. Vermis midline. Lesions instead cause truncal ataxia and gait instability. Left-sided appendicular ataxia without weakness points to a left cerebellar hemisphere lesion with ipsilateral signs. Which change would INC raise the statistical power of the study? Researchers design a trial to detect the true difference between two treatments, but worry their study may fail to detect a real effect, WA, type 2 error. They want to maximize the study's p-aware. Read the command. Which change increases power? Power is increased by increasing the sample size. Statistical power is the probability of correctly detecting a true effect, that is, rejecting the null hypothesis when it is actually false. Power equals 1 minus beta, where beta is the type 2 error rate. The single most reliable way to INC increase power is to INC increase the sample size. More participants narrow the confidence intervals and make it easier to detect a real difference. Power also rises with a larger true effect size, lower measurement variability, and a higher, less stringent alpha. But in a study, you most directly control power by enrolling more subjects. The correct answer is D. The factors that increase power, in order of practical control: larger sample size, larger effect size, less variance, and a higher alpha. The distractors do the opposite. Decreasing sample size, studying a smaller effect, or increasing variability all reduce power, and lowering alpha to 0.01 makes the test more stringent, which decreases power. It reduces type I error at the cost of type 2. To maximize power and avoid a type 2 error, increase the sample size. What is this cycle called, and what is the main purpose? During intense exercise, skeletal muscle produces large amounts of lactate, which is released into the blood. The liver takes up this lactate and uses it to regenerate glucose, which is returned to the muscle. Read the command, name of the cycle and purpose. Muscle lactate to liver, regenerated to glucose, back to muscle, the Cori cycle. This is the Cori cycle. During intense exercise, muscle relies on anaerobic glycolysis, generating ATP quickly but producing lactate as the end product. The lactate is released into the blood and taken up by the liver, which converts it back to pyruvate and then, through gluconeogenesis, to glucose. That glucose is released into the blood and returned to the muscle for energy. The main purpose is to shift the metabolic burden of gluconeogenesis, which is ATP costly, to the liver, allowing the muscle to keep producing ATP rapidly and to recycle lactate instead of accumulating it. The correct answer is A. The Cori cycle is metabolically costly. Overall, it consumes net ATP across the two organs. Gluconeogenesis costs more ATP than glycolysis yields, but it cleverly relocates that cost to the liver, sparing the exercising muscle and preventing lactic acidosis from runaway lactate buildup. Contrast it with the alanine cycle, which similarly shuttles carbon to the liver, but also transports nitrogen for urea synthesis. The lactate to glucose shuttle between muscle and liver is the Cori cycle. What is the diagnosis and its typical route of metastasis? A 50-year-old woman has a solitary thyroid nodule. Fine needle aspiration shows follicular cells, but cannot distinguish benign from malignant. After surgical removal, histology reveals malignant follicular cells that have invaded through the tumor capsule and into blood vessels, without nuclear features of papillary carcinoma. Read the command, diagnosis and route of metastasis. Follicular cells, capsular and vascular invasion, no papillary nuclear features, FNA cannot distinguish. Follicular thyroid carcinoma, hematogenic spread. This is follicular thyroid carcinoma. The defining feature is that the diagnosis cannot be made on fine needle aspiration, because benign follicular adenoma and malignant follicular carcinoma look identical cytologically. The distinction requires examining the whole resected specimen for capsular and vascular invasion. A follicular adenoma is encapsulated and contained, while a follicular carcinoma breaks through the capsule and invades blood vessels, as described here. It lacks the nuclear features, orphan antinuclei, grooves, psammoma bodies of papillary carcinoma. Correct answer is B. The route of metastasis is the key contrast with papillary carcinoma. Follicular carcinoma spreads hematogenously through the blood to distant sites like bone and lungs because it invades blood vessels. Papillary carcinoma instead spreads through LY emphysema to cervical lymph nodes and has a better prognosis. So, follicular invades vessels and spreads by blood. Papillary spreads by lymphatics. Capsular and vascular invasion of follicular cells, diagnosable only after resection, defines follicular carcinoma with hematogenous spread. Which statement correctly describes the mechanics at FRC? At functional residual capacity, FRC, the respiratory system is at rest with no airflow. A physiologist explains that two opposing elastic forces are in equilibrium. Rate the command, mechanics at FRC. At FRC, lung inward recoil balances chest wall outward recoil. Functional residual capacity is the volume of air left in the lungs at the end of a normal passive expiration, the resting equilibrium of the respiratory system. At this point, two elastic forces are exactly balanced and oppose each other. The lung has an inherent tendency to recoil inward and collapse because of its elastic tissue and surface tension. The chest wall has an inherent tendency to spring outward, to expand. At FRC, these two forces are equal and opposite, so the net force is zero and there is no airflow. The system sits at rest. The correct answer is D. This equilibrium explains what happens with disease and with the pneumothorax. If air enters the pleural space and breaks the coupling, the lung collapses inward toward its own resting volume, and the chest wall springs outward, revealing each structure's natural tendency. In emphysema, lost elastic recoil shifts FRC higher. In fibrosis, increased recoil lowers it. At FRC, the inward pull of the lung balancing the outward pull of the chest wall is the correct description. What is the diagnosis? And the best initial confirmatory test. A 45-year-old man presents with enlarging hands and feet. He had to resize his ring, coarsening facial features, a prominent jaw, increased spacing between his teeth, and headaches. He also has new hypertension and impaired glucose tolerance. IGF-1 is elevated and growth hormone fails to suppress after an oral glucose load. MRI shows a pituitary mass. Read the command, diagnosis, and best confirmatory test. Enlarged hands, feet, coarse features, problematism, high IGF-1, GH not suppressed by glucose, acromegaly confirmed by IGF-1 and OGTT. This is acromegaly caused by excess growth hormone from a pituitary adenoma in an adult after the growth plates have fused. Because the long bones can no longer lengthen, the excess GH instead causes growth of the extremities and soft tissues, enlarging hands and feet, coarse facial features, a prominent jaw, problematism, widely spaced teeth, and enlargement of internal organs. It also causes hypertension, insulin resistance, and glucose intolerance, and carpal tunnel syndrome. GH acts largely through IGF-1 from the liver, which is elevated. The correct answer is D. The diagnostic approach is the high yield point. Random GH levels are unreliable because GH is secreted in pulses. So the best screening test is an elevated IGF-1, which is stable. The confirmatory test is the oral glucose tolerance test. In a normal person, a glucose load suppresses GH, but in acromegaly, GH fails to suppress. Then MRI localizes the pituitary tumor. The same GH excess before growth plate fusion in children causes gigantism. Elevated IGF-1 with non-suppressible GH confirms acromegaly. What is the mechanism of this toxicity and the immediate antidote? A 22-year-old man is brought to the ED unresponsive with a respiratory rate of 5 min, pinpoint pupils, and cool, clammy skin. Track marks are visible on his arms. He becomes apneic. Read the command, mechanism, and antidote. Pinpoint pupils, respiratory depression, track marks, apnea, opioid overdose, MUA receptor agonism, reversed by naloxone. This is an opioid overdose. Opioids, heroin, morphine, fentanyl, oxycodone, act as agonists at mu opioid receptors in the central nervous system. The classic overdose triad is depressed consciousness, amiosis, pinpoint pupils, and most dangerously, respiratory depression. Opioids blunt the brainstem's responsiveness to CO2, slowing and eventually stopping breathing, which is the usual cause of death. Other findings include decreased GI motility, constipation, and cool, clammy skin. The mechanism of lethality is the respiratory depression from MUA receptor agonism. The correct answer is E. The immediate antidote is naloxone, a competitive mu-opioid receptor antagonist that rapidly displaces the opioid and reverses the respiratory depression. It can be life-saving within minutes. Because naloxone is short-acting, repeated doses may be needed as it can wear off before a long-acting opioid does. The pinpoint pupils plus respiratory depression is the opioid fingerprint. Naloxone is the antidote. Flumazenil reverses benzodiazepines, a different toxidrome. Which organism causes this, and what is its vector? A 30-year-old man who went hiking in the northeastern United States develops a slowly expanding circular red rash with central clearing, target bull's eye lesion at the site of a tick bite, along with fever, fatigue, and joint aches. Untreated, weeks later he develops facial nerve palsy and heart block, and months later a migratory arthritis. Read the command, organism and vector. Northeast US, bullseye rash, erythema migrans, facial palsy, heart block, later arthritis. Lyme disease, Borrelia burgdorferi, via Ixodes tick. This is Lyme disease caused by the spirocheted Borrelia burgdorferi and transmitted by the Ixodes tick, the deer tick, endemic to the northeastern and upper Midwestern United States. The disease unfolds in stages. EA early localized, the pathognomonic erythema migrans, an expanding bullseye or target rash with central clearing at the bite site with flu-like symptoms. EA early disseminated, weeks later, multiple erythema migrans lesions, facial Bell's palsy, sometimes bilateral, and cardiac involvement with AV heart block. Late, months later, a migratory monoarticular or oligoarticular arthritis, classically of the knee, and neurologic sequelae. The correct answer is B. The classic triad to remember for disseminated Lyme is the bullseye, Bell's palsy, and heart block, followed later by arthritis. The Ixodes tick also transmits Babesia and Anaplasma, sometimes as co-infections. Treat early Lyme with doxycycline or amoxicillin in children and pregnancy. The bullseye erythema migrans after a tick bite in the northeast U.S. with later facial palsy and heart block is Lyme disease from Borrelia burgdorferi via the Ixodes tick. Which pairing is correct? An immunology student studies cytokines released during a bacterial infection. One cytokine, produced by macrophages, induces fever, stimulates the acute phase response in the liver, and activates endothelium. Another, from helper T cells, is the major activator of macrophages to kill ingested pathogens. Read the command. Which pairing is correct? Fever acute phase from IL-1, IL-6, TNF, macrophage activation from interferon gamma. Two cytokine roles are described. The first, inducing fever, driving the hepatic acute phase response, C-reactive protein, fibrinogen, and activating endothelium, is the job of the pro-inflammatory cytokines released by macrophages. IL-1, IL-6, and TNF-alpha and IL-1 and IL-6 are the key endogenous pyrogens. The second, the major activator of macrophages, enhancing their ability to kill ingested pathogens, is interferon gamma, secreted by HE1 helper cells and NK cells. So the correct pairing is IL-1. IL-1, IL-6, TNF for fever and acute phase, interferon gamma for macrophage activation. The correct answer is D. A quick high-yield cytokine map, IL-1, IL-6, and TNF-alpha are the inflammatory fever. Cytokines acute phase, sepsis, interferon gamma activates macrophages and drives a Th1 response. IL-12 stimulates H1 differentiation in NK cells. IL-4 and EL-5 drive the H2 allergic response, and EL-10 and TGF-beta are anti-inflammatory. The fever and acute phase trio with interferon gamma as the macrophage activator is the correct pairing. Block 14 is done. Let's review the 5 biggest traps on this block. Trap 1. Ventricular free wall rupture occurs 4 to 7 days after a myocardial infarction, when macrophages have cleared the necrotic tissue but durable scar has not yet formed. The wall is at its weakest in that window. Trap 2. Acute tubular necrosis versus prerenal azotemia. ATN has a high FeNA and muddy brown casts because the tubules are dead and cannot reabsorb sodium. Prerenal has a low FeNA because the tubules are intact and conserving sodium. Trap 3. Cerebellar hemisphere lesions cause ipsilateral signs. The patient falls toward the lesion. Most pathways cross, but the cerebellum's double cross keeps its deficits on the same side. Trap 4, pemphigus vulgaris, targets desmoglein, giving flaccid intraepidermal blisters with a positive Nikolsky sign and oral involvement. Bullous pemphigoid targets hemidesmosomes, giving tense subepidermal blisters with a negative Nikolsky sign. Trap 5, follicular thyroid carcinoma, cannot be diagnosed by fine needle aspiration. You need the whole specimen to see capsular and vascular invasion. It spreads hematogenously, unlike papillary carcinoma, which spreads through lymphatics. 14 blocks, 280 questions. Train process, not memorization. StepLogic, learn how to think, not memorize.